Welcome to Flourishing in Medicine from Surviving to Thriving. I'm your host, Dr. Mick Krasner. This podcast is brought to you by EmPro, a medical professional liability insurance carrier located in New York State. And EmPro has been committed through educational activities and peer support activities to support the physicians that they cover and they protect.
I think of every technology, and I've been involved with multitude, right? So I had one floor clinical, one floor consulting. Bring in the latest gadget, let me try it and see how human beings interacted with it. And I call the latest and greatest technology, it might as well be the stone and stone soup. It's the shiny thing. It's not what's really important, and that's true whether I'm at a extremely large academic medical center. Right. It's the people that you bring around that technology in both ways that may be interested or uninterested in it. Some people, they're like, yay, that's coming. And other people are like, I can't stand that that's coming. And it's how do we gather the people around it and form a team, and how does that team function is so much more important than the technology. And then when you're down with an individual and a physician and interacting, yeah, I can have the technology, but I was at the point where I didn't look at the computer screen when I was in the room with a patient. I try not to. I don't bring it in. I use it ahead of time. I read, I make sure I understand, okay, this is where they're at. Then I want to go in and have a conversation, and now that's very different. So how are we using technology there too?
Today on Flourishing in Medicine from Surviving to Thriving, I'm joined by Dr. Alice Loveys. Dr. Loveys is a pediatrician, nationally recognized voice at the intersection of medicine, technology, equity, and human connection. Together, we will explore how artificial intelligence, digital health, and evolving technologies are reshaping medicine, and why the future of healing may depend less on what technology can do and more on our capacity to preserve awe, presence, humility, and the deeply human experience of caring for one another. So welcome to Flourishing in Medicine, Ali Loveys. It's just a pleasure to have you here. I'm so excited to have this conversation.
Well, it's great to be here. Me too. Always good to see you.
So I'm going to give just a little bit of a preamble, a little background. Future of medicine will not be determined only by what technology can do, but also by what human beings choose to value. And I think that's a place we can find common ground. So drawing from your remarkable trajectory from pediatrician to nationally recognized clinical informatics leader, blockchain strategist, I've seen it that you're called, quote, Dr. Gadget, an advocate for equitable digital health. This conversation really can become much more than a discussion about technology. I think it can be a deeper human question beneath this digital transformation that's happening in medicine. Things such as what happens to the soul of medicine when technology becomes the environment in which care occurs. And I should add, technology has always been part of medicine, so it's not like that part's new. Maybe more importantly, can technology erode or actually deepen human flourishing? So we're living it, as you know it, through one of the most consequential transformations in medicine since antibiotics. Artificial intelligence, blockchain, predictive analytics, digital surveillance, algorithmic medicine. All of this is really reshaping not only how we practice medicine, but how we understand what it means to be a healer. And beneath all that technology remains some ancient human questions: suffering, relationship, meaning, and care. You're someone, Ali, who has spent decades right at that intersection. You're a pediatrician, systems thinker, a bridge builder, a translator, really, I would see it, between these worlds, and someone who's lived both inside the relational intimacy of taking care of children and their families and the abstraction of large-scale digital systems. So before we, start talking about informatics and blockchain and really what it means to be Dr. Gadget, can you tell us about your human story underneath that. Why medicine? What brought you there in the first place?
A photographer, Leonard Nielsen. So Leonard Nielsen, and they actually give an award at RIT. There's a Leonard Nielsen award. He did the first photographs of a baby in utero. Fascinating. It was in the 70s, and it was on the cover of Life magazine. He has a book, A Child is Born, where you see the development of the embryo. It's just, that got me hooked with medicine and science. And I thought I wanted to be a neonatologist until I got in the delivery room and helped deliver the baby. And they're like, come take care of the mother. I'm like, I want to be with the baby. And I like the whole process. So it started, I was young when I got hooked and decided.
Take us back. What was it about that picture that what was the impact it had? How did you say emotionally, cognitively, even somatically respond?
Right. I mean, I think this is where I hope you can get one of the pictures and flash it up of some of his work and see it. I still think this, and when you're seeing a child for the first time and then the first 24 hours of life, I mean, you're laying your hands on a miracle. The whole process seemed miraculous to me. That's also, it's a sense of wonder. You're like, wow, that's really wonderful. And I was awestruck by it. So you've never seen the pictures?
Oh yes, I have. No, and the word you just used, awestruck. I think that's right. I mean, when we have that awe experience, it's sort of beyond ourselves. It's sort of something much larger.
It is. And sometimes I have difficulty describing it as you connect with your patients and with the families, because I think parents always remember that doctor that came in the very first, laid hands on their baby the first 24 hours. And then what if you're there at the end of the child's life? If unfortunately, like I've been there in that situation, and you're bonded to that family forever and you're connected. And it's hard to say, gosh, I was there through the whole life cycle and it was a privilege, even when you're there at the end. So privilege doesn't seem like the right word, but you're certainly there, and it's an incredible bonding connection. But that's what I look at. So I look at every kid that comes in. To me, it seems, little baby seems like a miracle. And certainly when you watch them go from birth to adults, and then I took care of some of my patients. I'm old enough, right, to take care of some of my patients' children and to see them become parents. And that's, the whole process to me is miraculous. And then the other side of my brain, Nick, is very concrete. You were laughing, like, say something. I'm like, say something. My brain works a little bit like a computer in that, to me, everything is a little, it can be when I'm trying to make decisions. There's always judgment, right? Technology isn't everything, but where things can be black and white, I'd like them to be black and white. There are just some things that are true or false, and that we don't have to expand a lot of energy on that. And that's where I think technology maybe could help. Like, this is the answer when you run a strep test and it comes back with a positive. That's a positive, right? That's, I can get that, and that's concrete. Now that I have a positive, there's steps to take after that. And where it should be black and white, I think that's where I would like to help a lot of physicians. There are times when we know the answer, and or we have the best possible guidelines you can follow with our current understanding. Doesn't mean we won't get better, but here today, this is our best understanding of it. It's tough to keep up on all that. So if we have tools now, and I think the tools are getting stronger and better, this goes beyond clinical decision support, how you can interact with the correct AI.
I think that's right. And I think we're gonna get deeper into this, and it's nice to see the human side, the humanity that informs how you have sort of used or related to technology.
You said something important though, and I just want to go back to what you said in the beginning, because I'm like nodding vigorously about that human connection. I think of every technology, and I've been involved with multitude, right? So I had one floor clinical, one floor consulting, bring in the latest gadget, let me try it and see how human beings interacted with it. And I call the latest and greatest technology, it might as well be the stone in stone soup. It's the shiny thing. It's not what's really important, and that's true whether I'm at a extremely large academic medical center, right? It's the people that you bring around that technology in both ways that may be interested or uninterested in it. Some people, they're like, "Yay, that's coming," and other people are like, "Ah, I can't stand that that's coming." And it's how do we gather the people around it and form a team, and how does that team function is so much more important than the technology. And then when you're down with an individual and a physician and interacting, yeah, I can have the technology, but I was at the point where I didn't look at the computer screen when I was in the room with the patient. I try not to. I don't bring it in. I use it ahead of time. I read, I make sure I understand, okay, this is where they're at. Then I want to go in and have a conversation. And now that's very different. So, how are we using technology there too? So, those were the two things that you said about people and the human touch that I thought, oh, that's the most important part.
Yeah, that's very refreshing and actually reassuring for someone with your background and doing the work you do. Reassuring to me and hopefully the rest of us in medicine to know that that's your orientation and that there are probably other people who have similar orientations. I want to share with you some thoughts of a couple of authors. You may be familiar with these authors and then get your take on what they're talking about. Atul Gawande, you may know, and he talks about systems complexity. And he talks about how modern healthcare has become so complex that no single clinician, no matter how skilled, can manage all its moving parts alone. He argues that improving outcomes depends not just on individual expertise, but on well designed systems, communication, teamwork, and structured supports. I'm also reminded of Ivan Illich, who's the theologian and social commentator who actually brought the word iatrogenesis into more common usage. His writings on medical nemesis in the 70s, where he warned that medicine risked becoming so dominated by systems, institutions, and technical control that it could unintentionally erode the very human dimensions it was meant to serve. So today, with AI, rapidly entering medicine, people are expressing concerns. I'm sure you hear it, that we may gain extraordinary efficiency and capability, but will risk distancing people from relationship, presence, clinical wisdom, the things you were just talking about that you do in the exam room, even professional meaning, which this podcast, if nothing else, is about trying to support docs to help them flourish. So, as someone who spent years at the intersection of clinical care and technological innovation, how do you think about that tension? And what do you think needs to be protected most carefully as AI becomes woven into the fabric of healthcare?
As we led up to this question, I mean, you have a lot of meat as you lead up to that I want to take small bites of. First of all, Atul Gawande should be required reading everybody, right? You need a checklist manifesto, right? Okay, and checklist manifesto can imply anywhere in your, it's a quick read. And so I tell people, read checklist manifesto. So I think that's the side of medicine that we need to get. No one person can do it right 100% of the time. And if you read the synopsis, it started with the airline industry, right? How do we fly so safely? What do you do when there's a crisis? They have checklists that pilots run through. And then he brought that to the operating room. And interesting enough, he even thought he didn't need it in the operating room at first, right? It's medicine, you have to have good doctors. And here's the crossroad. Even with technology, boy, you have to have a lot of humility, to say, I need this. I don't mind. I have mild dyslexia, so I love technology. That's how I kind of got into it. Computers could spell check and correct for me. And as I was trying to comprehend, and we can all comprehend and understand large volumes, but can I retain it and make sure I'm going to call it up with 100% accuracy for that person sitting in front of me? And I had the humility to say no, but I can make sure that technology is prompting me to make sure I get the right answer. So there's both, and that's what I was saying. My brain works both ways. You have to have that concrete, this is the answer, and then you have to have, here's the person in front of me and the conversation. And how are we going to translate those two things? So what needs to be protected is what you're asking. Most protected. A saying that I always say, if you want to see why something's done in healthcare, follow the dollars. And I bet, without any computational analysis, that 99% of physicians would agree with that electronic health records put a burden on them that they weren't anticipating. I was one of the early adopters, and I owned my practice. So we use electronic health records to be more efficient. And when I say more efficient, meaning I needed less staff to support me in doing what I did. So we ran a very fiscally responsible office. But when I had that better efficiency, what I did, instead of doing a previous practice, we had 20 minutes for a physical. Now I'm more efficient. I give a half an hour. So I spent more time with my patients. No 10-minute sick visits. No. 15, right? At least 15. I used efficiency that way. But then you get into the bigger settings, maybe larger groups, and they say, oh, you're more efficient. So now instead of 20 minutes for a physical, let's do it in 15. And let's see a patient every 6 minutes. And all of a sudden, they're like, it backfired on the efficiency. And oh, by the way, since we can collect so much more data with these electronic health records, let's collect so much more. So now I have less time to see the patient, but I have double the amount of documentation that I have to do.
I love the way you described that the use of it was actually liberating rather than you becoming a slave to it, that it actually liberated your time. Many physicians, as you know, and you're pointing to it, experience technology as less as liberation, more as intrusion, the electronic health record, this third presence in the room. And actually, in the literature on burnout, it's often described in technological terms, the language, fragmentation, overload, etc. Since you've been at the forefront of this, how did we underestimate sort of the psychological consequence of digitizing medicine? And what do you think, like the early architects of healthcare IT and the electronic health record didn't understand about clinicians?
Well, they didn't build it for clinicians. Let's just start there. And they say they did. And I'm not, I want to be careful, because if you look at some of the leading electronic health records, and I've touched over 100, the evolution and how much better they've gotten from where they came from for the provider. I can think of a few where I've watched over there and it's like, wow, they're getting better. And they've only done that by listening to their users and feedback and trying to do better. So I'm not saying that. The push, most of these started the first time we wanted to do something efficient with the computer's bill. Because those are really concrete numbers that I can put in and codes, and I can do it. So they were billing systems. And then the health record then had to feed the billing system. And so it's still based upon billing. If we took billing away and we were about capturing the story of the patient in front of us and then calling up the black and white things that I need to know about where we need to go, and then I can write the story of how I put it together, that's a whole different kind of intake system than one that says, I'll give you an example. For a diagnosis, if a child comes in with a sore throat, unless I put down a specific diagnosis, I can't get paid for the strep test. Now, that doesn't have anything to do with the story of that child's sore throat and my differential and how I thought about it, right? When I'm doing in that assessment, my assessment when I was a resident, it was a storybook. It's like, hey, this is what I thought about, right? I get my whole differential was in there, and they don't want my differential. Give me your assessment that you can bill for and the code attached to it and be done with the story. And so we had to make sure that was in, so we lacked a lot of the story. I hope I'm not diverging too much.
No, it's very on point. I'm thinking as you're talking about our colleague, Betsy Toll. Betsy published an opinion piece some years ago in the JAMA, I think it was called Cost of Technology. Did you see this? It was an opinion piece with this 7-year-old draws this crayon drawing, happy child in the center of the figure, off to the side, a smaller figure of the mother probably holding a baby. And then there's the doctor who is turned away from this child and is hunched over with the fingers on the keyboards. So, clinician suffering in some ways has maybe been mediated through screens rather than relationships. And you really described very well the relational aspects. And just maybe if you could just riff on that idea and how to actually just first be aware of that potential. I think it just takes awareness. Oh, I don't want to do that. None of us as clinicians want to be that doctor who's turned away, but we find ourselves without awareness really doing that. And we have choices in how we relate to and use the technology effectively.
Well, let me go with just the physical. So we were a very early adopter in electronic health records. So we're setting up the office and how do you do it? And there's the across the table setting where you're sitting there. I'm here, the computer screen's kind of off to the side. So I'm facing you. There's we're sitting side by side. I'm facing this way, you're facing that way. It's almost like, remember those love seats where they were both? And then there was a triangulation, right? Where we're both patient and doctor are looking at the screen together. We can face and talk to each other. And when we need to turn our attention to the screen, we do it together. So it's not a hidden. I think that triangulation was nice. When I got more proficient and trusted, I didn't even open the computer in the room. Sometimes my nurse would be like, the patient is here. Why aren't you going into the room? I'm engaging right now. Making sure I've read everything you wrote. I don't want to get in the room and go, hang on, let me read this and have them sit there and watch me read it. So when I walked in the room, I'm like, okay, I got the idea. I got the idea of why you're here. If it's someone I didn't know, I also knew their history. There was an organization that sometimes I filled in, right? There's an organization I worked for and the nurses I would be like, do I have a patient? And they're like, yeah, it's on your computer screen that the patient's here. I'm like, don't we need to talk first? And they're like, what do you mean? And I'm like, I need to talk to you. I know you wrote a note, but sometimes they'll talk and say stuff to the nurses that you don't. And I think it's that team effect. And it was interesting because they said, well, some physicians don't want to do that ahead of time and some do. So it's a style, but I always wanted to talk to the nurse ahead of time and say, okay, give me what brings them in. Because they also know the other thing too. It's like, oh, they're here today with dad. And I just want you to know mom passed away 6 months ago. Here he is, right? That they have more of a flavor of the patient that doesn't get captured in a family history, check the box.
I want to maybe move on to something perhaps inspiring or redeeming about this conversation. It's already been inspiring and redeeming, in my opinion. Maybe the unexpected humanity inside informatics, because I think it's there. Most people wouldn't immediately associate informatics with flourishing, meaning, or human connection, but I have a suspicion that you've seen something deeper in your work and you see it differently. In fact, I know you see it differently. Technology often reflects the values of the people building it. So, in some sense, informatics becomes kind of an ethical or philosophical project, not just a technical one. So, maybe if you can just describe moments where technology genuinely improved human connection or ideas of thoughtful design that actually reduce suffering. And just be interesting to think about in those terms. In what ways has it really helped humanism in this connection and relieve suffering?
From the end user, and who's the end user? Who's suffering? What kind of suffering? And I immediately, if I'm going to jump to where technology really has helped, it better be for the patient. That better be the answer. And some of this it's old because I'm old, and the transition I think we take for granted of electronic health records or what had to happen before electronic health records came into being. And one of my patients said it so succinctly. She called, I'm going to make up names, right? So Jane Doe said, I got little Susie. And she is, I think, having an allergic reaction. and how nice it was to have my office manager answer the phone, say, "Yep, I got Susie's record right here." As opposed to the old way of like, well, let me get it, let me get the doctor, let me see, let me pull the record, let me pull the chart, let's see, which could take how long it could take. I think she related, she just said it was just so comforting to her that they immediately could see what needed to be seen. I'm not really trying to make fun of dads, but it would go something like this. The dad brings the kid into the office, talk about it, what we think the child has, what we think we should do. Gets home, the mother calls. What did you tell him? Because I can't figure it out. It's a whole different thing when I can now create a summary of what we discussed. And that can sit in a portal that anyone can access, or I can print it out and send it home. We can look at it together. That's different. If physicians, and you're a physician, I can make fun of you, Anna. We can make fun. This happens sometimes. They'll talk in acronyms. If things just like roll off, and I've worked across so many industries and technology, and they used to call electronic health records computerized physician records. Oh, computerized patient records, CPR. Right? And so, I mean, it's just a classic. Well, we better not use CPR because it's confusing people. Do you know how to use CPR? And people are like, what do you mean, how to use CPR? But sometimes people can talk in acronyms. They can say a word that they're not going to say rhinorrhea to a patient, but maybe sometimes they do, or it even shows up in their note. And when they just mean runny nose, right? And so there's a language. I certainly feel a language difference when I'm sitting down with a different specialist in a different sector, say financial, sitting down, and they're speaking a whole different language. So sometimes we speak different languages, not intending to. So helping the patient there, demystify a little bit, right? Using technology. Do you know what it's like when I have a digital otoscope where the eardrum shows up on the screen for the patient? Do you know how fun that is?
Well, you're also educating and you're also confirming, and they're building trust in you because they can see you're not just making this up.
I did one of the first diagnoses of Lyme disease in the area. And at the time, again, this seemed radical at the time, but Kodak was one of the companies I worked with. And they gave me a camera, digital camera. It was medical grade digital camera. And this child came in with a classic bullseye rash, and we didn't have Lyme disease in the area at the time. He had been in North Carolina. I took a picture. I called ID. I said, I think, and they're like, no, we don't think so. Then I sent them the picture and they said, yes, we think so. We think so. So I just think about it in ways of use technology to really comfort the patient. Do you know what it's like now? Have you used one of the AI-driven stethoscopes?
I have tried them out. Yeah, I don't have one since I'm not practicing anymore right now, but yes.
So nice. I carry a couple different stethoscopes. Can you believe it? Someone coming in with like, can you follow up on this murmur? And I said, okay, let's run it right now and let's get it on it, get the recording done. What was fantastic for it? Do you ever use the teaching stethoscopes? Where you have the stethoscope on the patient's chest and other people are listening, you should still be connected with headphones. Well, I had an autistic child who he didn't like to be touched. His mom could touch him. So I was like, Mom, you put the stethoscope where I tell you to, and I can listen in with my headphones, and I don't even have to be near the patient. Have you seen the remote tools that parents can use? I don't own my own practice anymore. If I did, every single one of my families would have these. Question, does my child have an ear infection or not? This actually can do a guided exam, and it tells adjust, move here, move here, move here until you have a clear shot of the tympanic membrane, right? It does that. Does the same thing, cardiac exam, lung exam, right? And that's all happening remotely, and we can hear it all. Now, what made people happy? So there are other end users. We have to be fiscally responsible. I always think about being fiscally responsible. They did a large trial with a population that were recurrent users of the emergency room for asthma. And they gave them these kits. So from home, they could get an evaluation. There's nothing scarier than my kid can't breathe. There's nothing scarier. Well, there probably are, but that's pretty scary. Let's put it up there. So no wonder their kid starts with an asthma or even at the beginning, they're like, I'm getting there before this gets serious. I'm getting to the emergency room. Big difference when I can say, doctor, please, I'm worried. And can you listen right now? And I have that ability. So I think technology, I hope, has reduced suffering for the patient.
Certainly, those examples are great. Thank you. Um, right now, you mentioned AI assisted equipment. Right now, there's such an enormous excitement and, of course, anxiety about AI in medicine. And historically, we know this. Every technological revolution creates capability and disorientation, disruption. The printing press changed consciousness. The industrial revolution, yeah, industrial revolution changed identity. Germ theory, hand washing, social media changed attention, and AI may change professional meaning itself. So maybe just a little bit about what you are most excited about AI in medicine and what concerns you most.
Super excited about raising the bar for the consistency and quality of medicine that every patient gets. Sometimes there are very clear clinical guidelines on how to handle issues. If you ask 10 physicians how to handle an issue, you might get 10 different answers. And that bothers me. One of the answers can be, I don't know, and that doesn't bother me. But when a physician answers, all right, we're going to do this, X, we're going to do X, and I know they should have been doing X, Y, and Z, that bothers me. Because the patient doesn't know they were supposed to do Y and Z. I'm sure you've had relatives call you. I'm sure you have. And I'm very very careful. I don't know what the physician knows. I don't know what they've been told. I don't know the entire history. I never say, oh, that physician's terrible. Never. They should have known that. No, 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 no. But I will say, from what you've told me, let's throw it into, and I say that, but I love open evidence. Do you use open evidence? Yeah. What I love about open evidence, and for people that aren't familiar with that, so then we'd have to get into a little technology about AI and large language models and how we train a little bit, but how an AI model is trained is different depending on the AI model. Did I give it textbooks to read? Did I just scour the web for an answer? Or did I use supported literature and research and guidelines? So I only use in medicine, I don't ask ChatGPT, but I'll ask open evidence because that was trained on what's available in PubMed. All right. And the clinical guidelines for the various American College of Cardiologists, obstetricians, pediatrics, right? Show me the current clinical guidelines if we have them. And it will give you the reference for it. So I can go out and I can look at the reference. It's not making up law cases like, so you see the one in the Wall Street Journal where, yeah, in front of a judge. Now it's a little more important because we have a patient in front of us. So we really want to do it right. But when I can throw up into open evidence, just based on what you told me, and you're sure the physician knows everything you told me. That's the other thing too. This is X, Y, and Z is being recommended. Your physician only said X. Can you bring this back to a physician and show your physician this? Now let's talk about the human side of that. Will we empower patients in this relationship? I am always astounded. It's still a very, and I'm going to use the word paternalistic, it's an unequal power dynamic in that room. And can we balance that out? And will the physician accept that empowerment? Is that a good thing, or does it make does the physician feel less? And you can see where someone would be hesitant to bring it in because they don't want to be the problem patient. I don't want to question your authority, doctor. What about this? That's still there. And I don't think right now AI solves that.
Yeah, I think you're right. I think it's a question of the culture of medicine and also medical education, which I'm really deeply steeped in. And that cultural change has to occur concurrently with this technological change, which is happening so quickly. So it's challenging. Yeah.
This happened when the web really exploded. You'd have people come in with things printed out they'd gotten offline. I was fine with that. Not every doc was.
Right. To me, it's a sign of engagement, and you leverage that usually in your favor. Of course, there's always going to be outliers and problems, but typically that's a sign of someone who's really engaged, and that's what you want in your patients. They're going to.
That's what we want. That's what you want, Mick Krasner. That's what Allie Loveys wants. Do other physicians really want that?
Well, I think if we can change that culture so they can no longer live with this sort of paternalistic approach and say this is really a relational dynamic. And yes, we have a huge amount of expertise and experience, and we're working together.
But this has nothing to do with technology, right? Now you're back to the personal side, and we never want to lose that. And I think physicians, anyone who's providing care, and when I say physicians, we know we have nurse practitioners and physician assistants, we have physical therapists, OT. I mean, it extends. Big things happen in a team for sure. So, for example, on vacation, I got talking to some people, and the woman had shoulder surgery, and they did a reverse. Do you know right? They do a reverse shoulder. And she goes, I don't understand it. I still don't get it. She said, and my doctor could not explain it to me in a way that I understood it. And then I had a handout from him to take to physical therapy, what I was supposed to do, and my physical therapist couldn't understand what they wanted to happen. And I said, oh, well, did you let the doctor know? And no, they don't want to even let the doctor know that.
Well, one of the things that I've really appreciated about your work is it's been a through line from what I can tell, is your consistent concern for vulnerable populations. The philosopher Martin Buber, this concept of I thou relates deeply to your concern for vulnerable populations, because it reminds us that healthcare and the technologies that shape it must treat people not as data points, but as whole human beings whose dignity emerges through relationship, recognition, presence. So can you just talk a little bit about how technology could unintentionally widen these inequalities, this hierarchy that you're just speaking about, and what ethical blind spots worry you most right now with?
When I hear that question, maybe it's alien optimism or alien optimistic, because here's what I'm confident of. Have you ever met a person that says, you know what? I am biased. I know I'm biased. I'm biased. When this certain person that is of this age or this skin color or that gender or I'm a little bit biased and I treat them a little differently. So I look at it and I'm going to spin this around again in the concrete black and white of computers. I can take bias out of a computer. I cannot take bias out of a human being. Right? I've had physicians say at conferences, usually it's at conferences, you have a physician stand up and say, well, I'm not going to use that AI answer until I know the population data on how they were trained to that answer. And I said, great. When you make a clinical decision now based on clinical guidance, how do you know what population that was made from now? We don't know. We were taught things that were wrong in medical school, weren't we? Based on biased population sampling. How much research? I know it's gotten better. It's gotten better. How much used to be really white men? How far behind were we with cardiac care for women, for example? Okay, so I can't answer the question. I really can't answer the question for some current clinical guidelines, what population that was based off of. I really can't. But I really can when you put up the data set for how this was based on. I can look at it and say, this is representative of the population in question or not. I really can give you the answer there. We can't get the answer from the other one. So I get excited about that. Ethically, okay, now if I'm going to get concerned about ethically, and anytime I get concerned about ethically, I'm going to go back to the dollar. When decisions are being pushed in, and it happens now, it definitely happens now. Insurance won't pay for it. They won't pay for that diagnosis. They won't pay for this unless I've done this X, Y, and Z step before I can't do Z before I've done X and Y, even though I know you need to go to Z. I've got to go through this hoop. Ethically, you got to be really careful of who's in charge of what the final decision is and what is that based on. Now, that said, the calls for transparency are huge, right? We might hear like, does a patient know that I had to put down this diagnosis in order to get paid for this test? No, they don't. But I know that, and that's not transparent to the patient. Now it can be transparent. So I think we have more transparency ahead of us if we hold to transparency and explainability. How did I come up with this answer? Which we can't do for a lot of things now.
Two areas before we finish up. One is, you've inhabited really extraordinarily complex spaces, business, policy, technology, healthcare leadership. And these environments can really consume people that are working in them like yourself. And I'm just interested in, how do you personally sustain yourself? And how do you understand success for Dr. Ali Loveys over time, now at this phase in your career?
Well, my drug is exercise. That's my drug. And being outside. Those are the two. And in front of a computer, you're right. I'm sitting a lot. So getting up and moving, and make sure I'm getting up and moving. I probably would say that's one of the ways to balance it out. Connecting. And I think you have a perfect model of connecting, those dinner parties where you're sitting around the table. I have had this rule, and my kids actually were the first ones, if you can believe it. When my kids were little, cell phones were relatively new, and having two parents that were physicians, a phone ringing meant you're taking time away from them, right? No cell phones at the table was just a thing, and it is a thing. And I even had a sign put up, like, no cell phones at the table at our house, because that ability to talk and connect. And even if we're like, oh, I can look it up on my phone, it's like, it's more interesting to see what you can't look up on your phone and what you think might be
I
happening,
love it.
and talk about it, and who might know and how they might think about getting to the answer rather than just pulling it up. So one of my nephews brought a friend from college over, and the kid pulled out the phone, and I just like, cell phones at the table, and he kind of chuckled, and my nephew looked at him and said, no, she's serious, like, put that away. Put that away. And I say that because I just find the connection is better. And even if people want to show me photos or videos, and it's like, that's great, but not now. I'd rather have that. I want to converse. And if we can do it over good food, all the better. And of course, music, and music, I'm a big music fan of a lot of different genres.
As we begin to close, I want you to reflect on the following statement or question rather. When history looks back on this era, what do you hope that we will have protected, not just technologically, but humanly? Kind of another way to think about it is, what gives you hope right now? What do you think medicine most needs to remember? Like if you were a young physician, if a young physician was listening to this and was overwhelmed by the future of medicine, what perspective might help that person?
We can never underestimate the laying on of hands. It's one thing to listen to someone's lungs in an emergency thing, but it's a whole nother thing to say, come on in, let me see you. In some ways in telemedicine, we can see different, but I would say percentage wise, anytime you're over 20% in medicine, that's it, but 20% is the laying on of hands. When I say in my exam, even there's the listening and the talking is the most important, but that laying on of hands is really important. The role that you play for that person, that kind of mentor, guide, right guidance that you're playing to positively influence, empower, educate. You can still do that. That has to come from or with a human being.
Very well said, and what a great way to end what's been a wonderful discussion. I'm already thinking of ways to bring you back because I have so many more questions. So thank you so much, Ali.
It was great talking with you, Mike.
Thank you very much for listening to this episode. We will include a summary of today's podcast and links to Dr. Alice Loveys in the show notes. I'd like to conclude, as I typically do, by sharing another practical exercise to help you flourish. Take a few moments to sit comfortably with your eyes closed or open. Ali and I spoke about Atul Gawande's writings earlier in the podcast, and she referred to his book titled The Checklist Manifesto. And I'm thinking about how musicians, I know there's a big jump here, but bear with me, how a musician would never, ever play an instrument without tuning it first. Likewise, as we engage in our work, it seems like spending a few moments just to tune the instrument of ourselves would be a useful practice. So I'll share with you one way of doing that. In some ways, a checklist can be thought of as a way of tuning. So this is a very well-known contemplative practice called the body scan. And we can think of it as a way of tuning our instrument, our mind, body, emotional apparatus for meeting the day. So I'll guide you briefly in a brief body scan that you can consider to do anytime, that does not take much time, and that hopefully you'll consider using it from time to time as a way of tuning for your work, your encounters, your day. So it begins with just an awareness of the body, just as it is. Just noticing yourself standing or sitting as you're watching this podcast or listening to it. And then the instruction is just follow my guidance through the body. And if you find yourself distracted or elsewhere, not a problem. Actually, the awareness that you're distracted is very helpful. That's the moment that you're aware that you're not with my guidance. And you just bring yourself back. And if you have to do that over and over again, you just do so without judging yourself for having a normal wandering human mind. Let's just begin with an awareness of the feet just as they are, noticing sensations in the feet. No need to move them, no need to change, no need to have any other experience than the one that you're having. Noticing your ankles and your legs, the bend at your knees, the sensations of your thighs, feeling of the buttocks and pelvic region, either sitting on a chair or in a standing posture or however you are. The abdomen and low back, the chest, the upper back. Bringing awareness to the shoulders, the upper arms, the elbows, the forearms, the wrists, hands and fingertips. Directing your attention to notice the neck, the back of the head, the top of the skull and head, the sides, the ears, the forehead, the face, eyelids, nose, cheeks, chin, jaw, mouth. That's it. Tuning up. I hope you've found this podcast and the guided contemplation useful, and look forward to having you join us for the next episode of Flourishing in Medicine from Surviving to Thriving. To learn more about EmPro, please visit www.myempro.com. And if you'd like to know more about EmPro's peer support programs, please visit www.myempro.com/peer-support. If you're a physician or a medical student and in need of urgent support, please consider calling the Physician Support Line at 1-888-409-0141 or visit them at www.physiciansupportline.com. This support line provides a safe space to discuss immediate life stressors with volunteer medical colleagues who are uniquely trained in mental wellness and also have similar shared experiences of this profession. Until next time.